Good morning. My name is Helene Merlo. I'm the Director of Resident Billing and Reimbursement Contracts for Presbyterian SeniorCare. My objective today is to give you an overview of bundled payments, both from a general perspective and specifically related to the CMS Bundled Payments for Care Improvement Demonstration Project, which Presbyterian SeniorCare is participating in. We'll talk about the factors that led to CMS's very strong interest in this reimbursement method and the opportunities that this offers to both providers and residents. Finally, we'll discuss CMS's recently finalized CJR rule and its impact in the healthcare arena. Let's begin by describing what is actually meant by the term bundled payment. Very simply, under a bundled payment model, a payer makes a single payment for a complete episode of care over a specified period of time. The episode of care ranges from a single inpatient encounter to a full episode capturing up to 90 days of post-acute care. A bundled payment is smaller than the sum of the individual payments to the providers, meaning that providers who are taking responsibility for an episode can succeed by reducing costs and delivering more efficient care over the episode. So why is it that there's such interest in bundling post-acute care? As you can see on this slide, post-acute care not only makes up a large percentage of Medicare's fee-for-service spend, it has also been historically extremely variable, ranging from $60 per member per month to $450 per member per month. In addition to the cost factor, the current healthcare landscape has contributed significantly to the increased interest in bundled payments. The focus on hospital readmission rates has taught us that there are major opportunities around care transitions, with a shift toward integration and viewing previously vendors now as partners in quality. In addition, with shorter hospital lengths of stay and higher complexity patients, there really is a greater need for skilled rehabilitation and services. These factors brought about the introduction of episodes of care and bundled payments. With that came the opportunity and the imperative to foster strategic partnerships with the goal of improved care, better outcomes, and lower costs. I'd like to take a step back for a moment and look at how CMS has incentivized us to provide care, as this also explains how we've gotten to bundled payments. We began with cost reimbursement. This was a retrospective system where increased costs generally led to increased reimbursement, and the focus was squarely on the provider. When it became clear to CMS that this system was resulting in an unacceptably high cost, the rugs were born. Cost reimbursement was replaced with an attempt to tie reimbursement to resource use, and the system morphed from retrospective to prospective. However, it soon became evident to providers that increased provision of care, and by that I mean length of stay, longer length of stay, and intensity of rehab, led to increased reimbursement. As the providers worked in silos, concerned only with the patient while in their care, there was really no incentive to work closely with upstream and downstream providers. When RUGs didn't bring about the anticipated reduction in cost, we evolved to bundled payments, a system based on episodes of care and totally focused on the patient rather than the individual provider. CMS believes that this reimbursement system will incentivize providers to work together to assure smooth transitions of care for the patients and at the same time provide higher quality care in a more efficient manner. The next slide shows the current models in CMS's BPCI project. As you can see in the table, Model 1 is no longer included in the project, and Model 4 encompasses only an inpatient stay. Models 2 and 3 both include the post-acute period, with the main difference being that for Model 2, the episode of care begins upon admission to the hospital, and for Model 3, the episode is initiated by a post-acute provider. In both Models 2 and 3, the participants have the opportunity to select clinical conditions and episode lengths. And in both Models 2 and 3, episode costs include post-acute care, hospital readmission costs, physician services, outpatient therapy, labs, DME, and Part B medications. Continuing with the specifics of CMS's BPCI demonstration project, to qualify for Model 3, which is the model that includes SNFs and other post-acute providers, beneficiaries must participate in fee-for-service Medicare. They must be eligible for Part A and enrolled in Part B, and they must be admitted to the SNF for skilled care within 30 days of discharge from the acute care hospital. Additionally, their clinical condition must be one of a possible 48 clinical conditions based on acute care DRGs that the SNF has selected for participation in the BPCI project. As I mentioned, the SNF can choose from any or all of 48 possible clinical episodes. Each clinical episode is defined by the DRGs that are included in it. The episode begins when an eligible beneficiary is admitted to the SNF for skilled services and ends after a 30, 60, or 90-day period. Again, this is depending on what the SNF has chosen for its episode length. As I mentioned previously, the SNF can choose from any or all of 48 possible clinical episodes. Each clinical episode is defined by the DRGs that are included. The episode begins when an eligible beneficiary is admitted to the SNF for skilled services and ends after 30, 60, or 90 days. Again, depending on what the SNF has chosen for its episode length. Prior to determining a target price, the amount that CMS will pay for a particular episode of care, a baseline price must first be established. A baseline price is a dollar amount which is set based on diagnosis and historical claims data, and it represents the aggregate Medicare payment for items and services within a defined clinical episode. To get from the baseline price to the target price, a 3% discount is subtracted. Then on a quarterly basis, CMS reconciles the target price to the actual episode cost based on the claims submitted by all providers whose services are included in the episode. It's important to realize that all providers involved in the episode of care, including the episode initiator, continue to bill Medicare in the usual manner. For each quarter of participation, the total cost of claims for included services is compared to the applicable target price for the episode. If the total claim cost is less than the target price, CMS issues a check to the episode initiator. If it is more, the episode initiator must pay CMS. At the heart of the BPCI program are the providers' initiatives to improve quality and efficiency of care. CMS suggests a number of opportunities for the participant to implement, and I'll be discussing these next. Care redesign can include such activities as the implementation of clinical pathways and protocols to standardize care, both for the clinical episodes chosen as well as the common comorbidities that we see in the SNP. Enhancement in care delivery refers to items such as raising the level of interdisciplinary interaction and communication, telehealth, and advanced availability of care. Enhanced availability could include the provision of more on-site specialty services, such as on-site nurse practitioners, physiatrists, cardiologists, or respiratory therapy. The implementation of a nurse navigator or care transition coordinator is crucial to a provider's success. This individual has responsibility for following the residents in the program from hospital discharge throughout the episode. Through the nurse navigator, there are a number of opportunities to coordinate care throughout the episode. These include patient-level coordination between the acute and post-acute settings, coordination with the primary care physician, and coordination with specialty care. One of the most crucial aspects of patient-level coordination takes place around medication reconciliation. This is a huge area of risk to the patient, and as a result, presents an opportunity to minimize risk and assure that the patient is not only taking the correct medications, but is comfortable with his medication regime. As I previously stated, formation or enhancement of partnerships is key, and we'll talk more about that later on. Other opportunities for system changes to support care include the development and enhancement of IT systems to support care redesign and care coordination. Data-driven analytics are important to provide measurable feedback regarding what is working and what isn't. And again, provider-level coordination across settings of care is crucial. For Presbyterian SeniorCare, this has been a great opportunity to reach out and work with both upstream and downstream providers and to gain an understanding of the world from their perspective. We have found that most providers have been willing to work with us toward enhancing communication and coordination for the good of our common patients. Now that we understand a bit about the BPCI program, this should give you great insight into CJR, which you may have also heard referred to as CCJR prior to finalization of the rule. That's because CJR is based almost entirely on Model 2 of the BPCI program. The final rule makes participation mandatory for hospitals in 67 MSAs, which in Pennsylvania include Pittsburgh, Harrisburg, Carlisle, and Reading. The proposed rule has been recently finalized and published in the Federal Register on November 24th, 2015. The rule details a 5-year performance period which begins on April 1st, 2016. It bundles all services for hip and knee replacement procedures into an episode of care which begins at admission to the hospital for the surgical procedure and ends 90 days after hospital discharge. So you can start to see the similarity between CJR and BPCI. The clinical episode that is addressed by the rule is major joint replacement or reattachment of lower extremity, which includes DRGs 469 and 470. The only difference between the two DRGs is whether or not the patient has experienced major complications or comorbidities. There is a phase-in period so that hospitals who come in below the target price would be paid by CMS in year 1 of the program, but they wouldn't be required to repay negative amounts until year 2. Also, there's a 3-day waiver provision for participating hospitals, which begins in year 2. Under the waiver, a 3-day hospital stay wouldn't be required for SNF services as long as the SNF has a 3-star rating or above. CMS has clarified that the 3-star rating would be determined based upon the current information at the time services are provided. This is something that you want to be extremely careful with if you accept residents without a 3-day stay from a CJR hospital. Because the actual DRG billed by the hospital is usually not determined until several days after discharge, you'll want to feel comfortable that the residents you accept actually will have either DRG 469 or 470. If not, you're at risk for Medicare not paying for the resident's skilled stay. I'm sure that there'll be more details on this topic as we get closer to year 2 of the program. Now that we know that CJR will be a reality, and because it's likely that more payers will move to a bundled payment structure, how can a facility begin to prepare? As important as data is now, it'll become even more important in a bundled payment structure. Having an EMR that allows you to get quality data regarding your residents and their care will be key. As alliances are formed, you will need to be prepared with both demographic and statistical data that describes your resident population and your performance. Presbyterian SeniorCare participates in Clinical Connect, a health information exchange, and I can't tell you how much this has helped us follow our bundled residents throughout their episodes. Quality of care, particularly your ability to minimize hospital readmissions, will also become even more important. Addressing comorbidities from time of admission will be key, as will the ability to proactively assess residents and take action before their condition necessitates a hospital readmission. Finally, and this is a recurring theme in bundled payments, partnerships will be essential. This is the case for both upstream and downstream providers. You'll want to enhance your relationships not only with your referring hospitals, but also with the home care agencies that work with your residents after discharge. Excellent communication with all of your partners will be essential to assure that everyone is on the same page throughout the episode. Finally, it's important to understand your partners and referral sources and learn what their needs are. We're definitely entering a new world of healthcare, one that will require us to leave our silos and work together with other providers to meet the needs of our residents. This brings us to the end of our presentation. I've included my contact information on the PowerPoint, so feel free to get in touch with me if you have any comments or questions. Thank you.